distinguished international speaker, Dr. Nancy. There she is. Welcome, Doctor. And our respected chairperson, Dr. Ram sir, whose presence truly elevates this event. So, welcome, sir. To mark the beginning of this program, we'll commence with a lamp lighting ceremony symbolizing the light of knowledge and new beginnings. And we look forward to a meaningful and insightful session together. So, if I may request our speakers who can just come forward and we can just light the lamp.
हाँ हाँ प्रेजेंटेशन है ये चेंज करना है हम मिनिमाइज कर दो चेसिस शेयर कर ये वाली है ना Okay. Good evening, all of you. I'm Dr. Atul Sharma. I'm part of the medical and scientific affairs at HALEON. It's a privilege and honor to be present here along with you all. Uh, so, we all know Dr. Ram Chaddha is one of the most distinguished and well-known orthopedic surgeon in India and of course, across the globe. Uh, and we have Dr. Nancy Lane. She is the distinguished professor of medicine and rheumatology, our international speaker from UC Davis School of Medicine, California. She's also professor of medicine and rheumatology at the Stanford Medical School. So we'll hear from both of them and we'll invite them for, on the discussion and of course, Dr. Nancy for her talk. Before I invite Dr. Nancy, I'll share some data points with you just to, provoke your thoughts on OA, the prevalence and, the burden that it has in India and globally. So, it's a lag change. See, it's changing. Please see. इससे नहीं होगा, नहीं हो रहा है, इससे भी नहीं हो रहा है। मैं कर रही हूँ, नहीं हो रहा है।
अभी आप देखिए,
ओके,
देखिए
okay, so I'll just be sharing some data points with you on OA. So if you talk of OA global burden, this is data from last 3 decades. So globally, 595 billion suffer from OA. In last 3 decades, that has increased of 132.2%, which is from period of 1990 to 2020. It is further projected to increase by 74.9% for knee OA, 48.6% for hand, 78.6% for hip, and 95% for other types of OA by 2050. Now, if you look for adults adjusted for more than 70 years, OA is ranked as the 7th most common cause for years lived with disability. So it impacts, almost all countries across the globe. Some have higher prevalence than other, and the prevalence globally is on an increasing trend. What about India? So India, OA affects around 20 to 39% of the population and is one of the serious public health concern. So burden has increased from 23.4 million to around 62.3 million in the last 3 decades, on the same period of 1990 to 2019. So geographically, across Indian states, it has prevalence. And again, the trend is that it is on rise. So if you look into the severity in the Indian population, so 47% of Indian have mild, 35.9 have moderate, and around 17% have severe OA. In all age groups, the age standardized prevalence of OA is higher among women as expected versus men. So approximately 40% of population aged more than 70 years show OA, in which nearly 2% have severe pain and disability. So increase of OA, incidence increase of OA by tenfold amongst people with age, from 30 to 65 years. And the contributing risk factor, as well known to us, are obesity, increasing age, gender, educational background, and of course, occupation. Now, as OA, it has impact and has a disability cost, direct, indirect, intangible. We all understand, and I'll not go in detail. But just to give you an uh, cost of managing OA. So, if you look at the cost of direct and indirect medical management of OA of knee, it is reported somewhere around 20,000 Indian rupees. And for surgical cost, it is between 1 to 5 lakh for across India. Just to give you an overview, what is the management option and what are the strategies. So the strategy remains reducing pain and discomfort, maintaining joint stability, and avoiding functional loss. So various modalities, pharmacological, alternative medicines like Ayurveda, homeopathy, more so part of the world, intra-articular injection, surgical, herbs, some futuristic, therapies like laser and non-pharmacological, therapies, physiotherapies, etc. And upcoming and used for some time now are supplements and nutraceutical like chondroitin, glucosamine, omega, vitamins, and UC2. So this is just to give you an overview, how are the global recommendation, guidelines for various therapeutic options. So, the darkest green are the strongest level of evidence. The darkest red is strongly against. So if you, look across oral NSAID, topical NSAID are, propagated or positioned across various guidelines along with intra-articular corticosteroids, whereas the other The other therapeutic options are, recommended by some and not so, well positioned by some other guidelines. So acetaminophen, paracetamol less than 4 gram is commonly used. So topical capsaicin not, that commonly recommended across. Glucosamine, chondroitin, almost, out of recommendations. Tramadol, again, an opioid, not that strongly, evidence-based use. Intra-articular hyaluronic acid, again, although recommended by some of the guidelines, but not so by others. This is from a recent trend, so, which is kind of integrating the other therapies into the management algorithm, wherein undenatured type 2 collagen is part of the step-up approach in osteoarthritis management. This is only recently coming into picture, and the guideline, give a step-up approach of using various therapeutic option in management of OA. So why UC2? So undenatured collagen type 2. So this is a nutraceutical supplement, and I'll just share the brand that we have as HALEON, which is Centrum Joints and Mobility. So it contains UC2, which is undenatured collagen type 2. It is a unique process, and Dr. Lane would dwell in detail. But just to give you overview, the important nuance is that the extraction process maintains the triple helix structure, maintains the epitopes, maintains the regions of the collagen which are responsible for generating the antigenic response, which is what is the unique about UC2 in terms of its management, and mechanism of action. So not all type of collagen supplements are same. So, the nuances play a role. So maintaining the cross linkage, collagen triple helix, and maintaining the epitopes, which defines how undenatured type 2 collagen, remains in insoluble, not getting destroyed in the gastric pH, retaining the structure, which is what, leads to the antigenic effect, which leads to the T regulator cell stimulation, and thereby stimulating the anti-inflammatory response and the cartilage regeneration response. And Dr. Lane would again talk of that in detail. So this is just to show the comparison that extraction process actually defines, although those available as undenatured collagen, but if you see structurally, because of the extraction process, their native structure tends to get destroyed, whereas for UC2 the structure remains intact, and hence the antigenicity is maintained, which actually is deciding for the dose. So the other undenatured collagen will be required, 1 to 6 times more to have the same effect, which is not for UC2. So this is the brand that we'll be talking today, or the science behind the brand, which is Centrum Joints and Mobility. So it contains UC2, undenatured collagen type 2, which is a patented US patented company from a company called Lonza, along with vitamin K2 MK7. Again, this vitamin K2 MK7 is clinically proven for its joint mineralization, bone mineralization benefit, along with vitamin D3, calcium, zinc, manganese, and copper, which are overall required for maintenance of joint health. Once daily usage is what is recommended. So vitamin K2 MK7, because it helps in the bone mineralization, it is the soluble form. So it's a micro encapsulated with better bioavailability. It keeps calcium away from the arteries, thereby reducing the risk of calcification, which is seen with other type of vitamin K. So with long half-life, so once daily dose is the perfect for vitamin K2 MK7. So with this, that's it from my end, and may I invite Dr. Lane for her presentation. I'll just, yeah.
evening, and thank you everyone for coming out on Friday evening and Good Friday. It's a pleasure for me to be here tonight. And I'm going to talk now a little bit about a novel treatment for osteoarthritis. And we're going to spend time talking about what I'll call UC2, the undenatured type 2 collagen. And I'll refer to it in my talk as UC2. And now I'll take you a little bit on a journey of how I became interested in, if you will, the nutraceuticals and where we are today with them. Okay. We're almost there.
No, it's working. Yeah.
Okay. Okay. So let me start with what I hope everyone in this room will agree to about the management of osteoarthritis. As was said, if there's an illness of which people offer many remedies, you can be sure that that illness is incurable. And unfortunately, that is osteoarthritis, at least of the knee today. But let's talk a little bit about how we usually go about treating it. The American College of Rheumatology made some recommendations a few years ago, and they make a lot of sense as we take our patients through their journeys of osteoarthritis. We always start non-pharmacologically, giving education, exercise, weight loss if appropriate. Then we go to the low-grade anti-inflammatories, analgesics, acetaminophen, which, by the way, may actually be taken off this list soon, over-the-counter nonsteroidals, nutritional supplements, topical NSAIDs or oral NSAIDs, the COX-2s, eventually stronger things such as opioids, then surgery with intermittent steroids and hyaluronic acid. And we all use those with our patients as they go through the journey of worsening osteoarthritis, especially of the knee. Now, many years ago, I participated in a study looking, if you will, at nutraceuticals and their effect on osteoarthritis, painful osteoarthritis of the knee. This was really quite a big study. We recruited subjects all over the United States, and we put them into different groups. And at the end of the study, as you can see here, that the improvement in pain was actually not different from placebo and glucosamine and chondroitin. And the one treatment that did seem to work better was celecoxib. After this study in the United States, people stopped recommending these supplements. And so that kind of went away. Now, let's talk a little bit about cartilage and how maybe we can look at this from a different way. Cartilage is a wonderful, wonderful material, allows us to walk. It's made of collagen, of proteoglycans, and water that comes in and out of the tissue like a sponge. When we walk, the water goes out, and when we unweight our joints, the water comes in. Now, within that cartilage is one type of cell, chondrocytes. They're amazing cells. Why? Because they get these signals to chew up their cartilage, to break it down, and then they get signals to build it up and to make it. Normally, this process is very well balanced. However, and the type of collagen that's in the cartilage is generally type 2 collagen. It's kind of like the glue that keeps the proteoglycans and water together. Now, what happens in osteoarthritis? There's probably a mechanical pathway for most of our patients that results in the cartilage breaking down, some release of cartilage that starts up the immune-mediated reaction. Here comes this inflammation. Here comes the cytokines, destruction of the cartilage. Okay. Now, what about T cells? Now I'm going to start to bring in a little immunology. Not too bad because it's Friday night. I'm going to keep it simple. We have many types of T cells, but we're going to talk about them tonight as pro-inflammatory Th1, anti-inflammatory Th2, or the T cell we talk about so much today, the Treg. And why is it important to separate these T cells? Well, the Th1 cells, they make interferon, which upregulates the immune system. The Th2 cells make anti-inflammatory cytokines. We don't talk much about these in rheumatology, but IL-4, IL-5, and IL-13. And the Tregs, sorry, I got to go back. The Tregs, they make very important anti-inflammatory molecules, TGF-beta and IL-10. Okay. So Now let's go back to UC2, undenatured type 2 collagen. What's the mechanism of how it works? As best as we know today, this is the process. You take the medication, the UC2, it gets absorbed into the GI tract. What happens is there's a whole bunch of lymphoid tissue sitting right next to the GI tract. The UC2 goes into that, travels then to the mesenteric lymph nodes. It then interacts and Treg cells are made. The Treg cells, what do? They increase the anti-inflammatory cytokines, IL-10 and TGF-beta. They decrease the pro-inflammatory cytokines, end result, reducing pain and inflammation. Okay. So now, how do I know this? Well, a long time ago, we actually did some studies. This is an animal study in which we gave oral administration of undenatured type 2 collagen and looked at how it affected a rat model of osteoarthritis. And I'll take you through this really quickly. We took male rats. We took some of their meniscus out. Then we treated them for 7 days a week for 8 weeks. And we looked at outcome measures that are very standard for animal models of osteoarthritis. We looked at how much weight they could put on their joint, and we looked at the pathology of the cartilage and bone. And as you can see in this slide, very nicely, compared to placebo, type 2 collagen allowed more weight to be put on that joint. Also, the cartilage appeared to be maintained better than in the placebo model, and the bone tissue was also of normal structure. So what is this type 2 collagen? Well, it's undenatured. It's type 2, which is the type of collagen that's in the cartilage, versus type 1, which is in the bone. And it does come from an animal. So that is definitely what it is. Okay. But there's differences in the market of the type 2 of collagen. UC2, it's undenatured type 2 collagen. It's an intact structure recognized by the body. I showed you oral tolerance, versus denatured type 2 collagen, which is also available, but the structure, as talked about before, is destroyed, not recognized by the body. There's no oral tolerization that we know yet. Okay, let's have everybody take a minute. New people sit down. We're just about to hit the clinical evidence. What do we know about this agent in the treatment of osteoarthritis and inflammatory rheumatic diseases? Okay. Now, I like to show this slide, although it is old, because this is the first time in rheumatology, immunology, that anybody really thought much about type 2 collagen. And David Trentham at Harvard did a study published in Science, which meant it was highly important. He took patients with rheumatoid arthritis that had active inflammatory disease and treated them with type 2 collagen or placebo. And I'm going to show you what he found. It was a double-blind randomized trial, 60 patients. All their immunosuppressive drugs were stopped. Remember, back then we didn't have very many. And they had 3 months of treatment, either placebo or oral undenatured chicken collagen. And then he gave one dose, 0.1 milligram a day for a month, and then he increased it. What were these patients like? Well, look, they were our rheumatoid arthritis patients. They were about 50 to 55 years of age. They'd had 10 years of disease. And most of them were taking prednisone, and they were pretty sick. What did he find? This I couldn't believe. After 3 months, if you look carefully at the baseline of the collagen, undenatured collagen or placebo, number of swollen joints went down from 12 down to 9. Tender joints went down from 16 to 5 or to 10. Morning stiffness went from 155 minutes to 56, so really went down. And the patients really felt better. Sedimentation rate, a good measure of systemic inflammation, went from 40 to literally 1.7. So pretty amazing results in rheumatoid arthritis, which is highly inflammatory. I was very impressed. So that was a long time ago. What's happened since then? What's happened since then is the world has taken some interest in understanding and utilizing UC2 collagen for osteoarthritis. Now, I'm not going to go over all the studies that have been done because we'd be here till tomorrow, but let me go over a few of them. The UC2 brand has really been shown to have positive results in a range of studies. If you look over here on your right-hand side, you'll see that there have been 12 studies in OA subjects. A lot of them have been double-blind. The total number of patients in these studies is over 2,000. And the age range, which is kind of important for where we think this agent would fit in our therapeutic armamentarium, is really between the ages of 20 and 80. What do we have? Okay. So one of the first studies that was done, which is very interesting, was done in people who got knee pain from exercising in a gym. And they just had knee pain. They didn't have osteoarthritis. And so they were given these study subjects were given either placebo or UC2. There were a few more females than men. There were about 45 years of age. So people that got, say, patellofemoral inflammation from the gym, and they were not heavy. They were treated for 120 days. And when I can show you here is at the end of that study, those patients on UC2 had significantly more increased range of motion in their knee compared to those on placebo. And then you say, okay, that's good that their knee could extend more, but probably more important is that their WOMAC scores improved. So that's pain, stiffness, and function. And it improved, but look very carefully. This is going to come up time and time again. It took about 30 to 60 days to start to really see the changes. And when they looked at pain induced by going up and down stairs, you can see that the UC2 was much more effective than the placebo. Remember, these are people that have musculoskeletal, not necessarily OA, but you start to see the difference at day 60. So patients had to be patient. Okay. And when they looked at time to onset of joint discomfort, you can see that the UC2 was much better at prolonging the time without joint discomfort. Okay. So that was an important study because it really put UC2 from rheumatoid arthritis to musculoskeletal pain of athletes. But now, what about an example of looking at another outcome? Now, this outcome is undenatured type 2 in healthy subjects, but looking at a different outcome measure, which some of you may or may not have heard about, and that's called the COOS. What the COOS is, it really looks at people that are athletically active, how their activities change when they take a medication. And although I don't think we have that slide of the answers is the COOS improve more with the undenatured UC2 than with placebo. Now, let's go to OA subjects. Okay. First study done here in India was very interesting. It was small, proof of concept, looking at UC2 in the treatment of OA of the knee. Small study, about 50 patients. They were about 60, a few more females than males, and most of them had osteoarthritis more in the right knee than the left. What did they find? Looking at WOMAC, which is a score of pain, stiffness, and activity, that when you went out, after you got past about 30 days, the patients on UC2 did better than those on placebo. And this was important because this was a proof of concept study that this was going to work in disease. Okay, bigger study done. I participated in this in helping analyze the data done here in India. This is randomized, double-blind, placebo-controlled trial, looking at UC2, not only against placebo, but about glucosamine and chondroitin. What did we do? What did we find? We had 3 groups of study subjects, about 50 subjects per group. Again, the primary endpoint was the total WOMAC at day 180, and secondary endpoints were other pain measures. Patients were seen frequently. There were 13 clinics. Maybe some of you participated in this study. What did we find? Well, if you look carefully here at this, at the graph, you can see, okay, at 30 days after starting the study, they're all pretty similar in terms of their reduction in WOMAC. But then as you get out to day 60, you start to see the UC2 separates, and those study subjects got much more improvement in their WOMAC scores than either GC or placebo. This was a very robust finding. Another study now, we're leaving India and we're heading for Brazil. Now, this is an ethnically different group of study subjects, more Latino, and some Asians. And they again looked at undenatured type 2 collagen for the treatment of knee-OA. A little bit smaller study, this time is just against placebo. Patients were 60 to 80 years old, so they're a little bit older. And they were looked at baseline 30 and 90 days. Now, this again is very interesting data. When you look at the baseline and then 90 days later for pain scores, VAS, the UC2 patients have 50% more reduction in pain. When you look at the physical activity, they improved, and this is at 90 days. And if you looked at the WOMAC, again, significant improvement in the UC2 at 90 days compared to the placebo. Now, sometimes I've given you a lot of data about the WOMAC. The WOMAC is pain, stiffness, and activities, but we don't always break those down. So I thought this study, although small, looks at UC2 versus glucosamine, so it's an active comparator, and looks at the different parameters that these instruments measure. Now, this is a small study, only 40 subjects. They had radiographic OA, and they were looked at for 6 months. And if you look at the subscales of the WOMAC, what interested me about this study, as you can see, this, oops, let me just go back. Oh, hang on. Okay, you can see that compared to the glucosamine and chondroitin, which is the darker color, that when you look at the different pain parameters, you can see that UC2 did much better compared to glucosamine. And when you looked at stiffness, again, better in terms of morning stiffness was down and intensity of the stiffness was down. Functional parameters, not every single one of them was better in the UC2 compared to glucosamine. So this is really what you can talk to your patients about, because this is really what they care about. And this is where you know whether you're going to have efficacy. Now, again, we've gone from India, we've gone to Brazil, and now across the Asian continent, a study of 100 subjects. What I really just want to show here is in a purely Asian population, again, when you get past about a week, that there's significant improvement with UC2 versus placebo, and the effect continues out to 90 days. So we've really shown a lot of efficacy over the last 8 years regarding this therapy. So how do I sum this up? Summary of the UC2 undenatured type 2 collagen. It's once a day treatment. The proposed mechanism of action is anti-inflammatory signals at the OA joint. It reduces pain, stiffness, and improves function in subjects with mild to moderate knee OA or just knee pain. Its efficacy appears to be observed across different ethnic groups, and to date, there are no significant safety signals. So I'm going to stop there. Thank you all for your attention, and we'll take some questions.
Thank you, Dr. Lane. Maybe we'll request the hotel guys to put the chairs, please.
Good evening, everybody.
Sir, we'll request them to just put the chairs. So
Sure.
please bear with us.
Sure. We've had an excellent presentation by Dr. Lane, and I'm really happy that she's been here for some time, spending time with us. First and foremost, I understand we are a group of doctors here who are subspecialists. So just as a show of hands, may I know how many are physicians? All right, thank you. How many are surgeons? Fine. How many are healthcare providers indulging in physiotherapy and supportive care, palliative care, etc.? All right. Any other subspecialty? Rheumatologists? Nice. Any endocrinologists? So most are internal medicines and there are surgeons. So there is going to be a sort of a discussion of how much it will help non-surgically versus how much it will help surgically if you were to use it as a co-prescription. So I would first and foremost request any one of you, if you have any hot burning question to come up with this, please introduce yourself. Please tell us which subspecialty you belong to and be happy to address the lady. We also have our colleagues connected from a couple of other centers. Am I right?
Yes, sir. More than couple. Yeah.
Yeah, and they would be happy to be asking questions as well. But before we sort of keep it open to everybody else, may I request any one of the physicians or surgeons to please introduce yourselves and ask the first question. Because for us surgeons, it's been a very, very educational journey, more of a pilgrimage. And as we always say that we in our country move from homeopathy to allopathy to Tirupati for most of the ailments that we cannot treat. But I'm sure there is a way out. And I would request somebody to take the first question. And
So meanwhile, the chairs are.
yeah, ma'am, please be
ma'am.
seated up there. They're giving you pride of position. Anybody, any questions? And microphone is here. I would hand this microphone over to be moved
Yes, sir,
around.
we have more, so we'll
have
take
more?
it to them.
All right. Okay. Fine. Anybody, please get up and ask a question. If not, then you'll have to have a stupid orthopedic spine surgeon asking questions. Yeah, please.
Hopefully not stupid. We have undenatured collagen type 2. We have glucosamine. We have MSN, chondroitin, nanocurcumin, piperine, lots of stuff. Would you recommend using all of them together as giving it full whammy to the patient, hoping one of them works, or would you advise against it?
That's a great question. How do we, there's three or four types of nutraceuticals, and how would I use them? Well, I guess I wouldn't use them together because that's a lot of, I don't think there'd be a reason not to, but I probably wouldn't because I never would be able to figure out what worked. So I have patients that come to see me and ask me about glucosamine and chondroitin. And I tell them that I participated in the study that showed pretty well it didn't work, but if they are going to try it, I recommend they try it. They stay on it for 2 to 3 months, and then they stop it and they see if it did anything, if that's what they want to do. But I also will offer them UC2 because I have more data, a little bit of more of a scientific premise as to how it might be working. But I also tell them the same thing. I say they come in with generalized OA or knee OA or hand OA. I said, you can try this. There's some science to support that it may help you, but you need to stay on it for at least 3 months, preferably 6. Then you can stop it, or you can decide if you're better and continue it. I think the important thing is patients are different. They respond to different things. But at least I try to start with something where there's a little bit of scientific evidence. I probably would not use them all together because you would be taking a lot of pills each day. Good question.
Any other questions from anybody? Please introduce yourself, get a microphone so that everybody at the other centers can hear you. And may I?
What is the maximum duration for recommendation of UC2 for OA, mild to moderate?
Great question. Duration of use. If you start it, you can, there's no end to how long you can use it. If the patient is feeling some improvement, you can continue. As you know, sometimes the patients have some pain and then it goes away for a few years. Sometimes it comes back and their disease progresses and they may need surgery. But if the patient feels there's efficacy and you think there's efficacy and they're tolerating it, they can take it forever. Good question.
The second question is, after doing knee replacement replacement, do you recommend UC2 for post-operative osteoarthritis?
That's another great question. I'm going to ask my orthopedic surgeon what he would do. I know what I would do if, as the patient's going into surgery, but I want his answer first.
Well, I'll be very frank. I'm more of a spine surgeon, less of a knee replacement surgeon. And most of my colleagues seated here are replacement surgeons. So when they are doing one knee at a time, I'm pretty certain that they would supplement it with medical management till the patient buys the second surgery. But there are many of them who come in a very, very bad shape and they are subjecting them to both knees. But please do understand that somebody who has bilateral OA knees also has some subclinical disease in the other joints.
That's right. That's right.
And it's worth the while spending your time protecting those joints as well. So that's how I would look at it.
Yeah, I want to echo that exact thing. One knee can be replaced, the second knee replaced. Often there's osteoarthritis in other anatomic positions. It's fine to continue this if the patient has found that it helps. So if they're doing well on it, they seem to be improving, there's no reason to stop it.
I think there's a question at the rear. If you could hand over a microphone there, please. Please introduce yourself and ask the question, sir.
Good evening, sir. Myself, I'm Dr. Shivraj Jadhav. I'm an orthopedic surgeon. So my question is regarding UC type 2. Are there any contraindications for this molecule? Maybe in some comorbid conditions like diabetes or some other thyroid conditions? Because geriatric population is having a number of medicines, as you rightly said. And is it okay to continue because any interactions I'm interested in?
Well, that's a very, very good question. One of the contraindications for glucosamine chondroitin is actually diabetes. But UC2, there are no medical contraindications. As long as the patient finds they can tolerate it, there's no contraindications unless they have an allergy to the chicken type 2 collagen, which would become, I have not seen that, but I think it's been reported and they would know it very soon. Also, I guess it's also worth mentioning that it is an animal product, so your patients that are strict vegetarians may not want to use it, although it will be up to them if they decide to compromise for a supplement.
Thank you, ma'am.
Great question.
Any other questions? Yes, sir. Gentleman in front. Yeah.
Madam, I'm Dr. Zubair here, orthopedic surgeon from Bombay. I'm personally been taking this for more than a year,
Okay.
and probably it's nearing 2 years. I even don't know when I started. So, being a very aggressive badminton player, there's a lot of wear and tear which is happening in the knee, and I'm touching 52 now. So, it has been a great experience taking this molecule personally. And just a question, your studies in terms of doing an MRI after taking it for 6 months or 1 year, did you had an experience to know before you have started and the end of the 6 months or 1 year, there were some changes in the cartilage regeneration in the MRI?
Okay. I think that it's a little bit too much of an ask. A cartilage probably, I mean, it could be studied, and I think the answer would be that you would see potentially less breakdown, but but the biology of cartilage is such that this would not stimulate new cartilage, but there would be a lot to suggest based on these symptomatic, these improvements in pain and stiffness and increased activity level, that it could be reducing the loss for sure.
And what is your take on, if at all, how about taking 80 milligram OD? This is 40 milligram.
So double the doses.
I think it's fine. I don't think that there is an upper limit. I think it just matters that the good news is you only have to take it once a day, but if you're tolerating it, that would be a great set of studies to see if increasing the dose. I mean, it takes a long time in the nutraceutical world to get studies done. And I'm very impressed since I was here 8 years ago. I don't know if I met any of you. There's been a lot done since that time. your question is good. How about higher doses? Those things could be looked at now. In the Centrum, which you have, it's got a dose. Okay, so when it's mixed in with other things, that's probably what's approved is the amount that's in the supplement. But if you could do other studies with higher doses.
Thank you.
I didn't look too much at that in the studies. Somebody may comment on that.
So, sir, from our point of view, we would recommend it to be once daily, which is 40 mg. And to your question on the dose, so we don't see many studies which highlight that increasing the dose or making it double would have better therapeutic outcome. And hence 40 mg is the recommended dose globally. So,
Thank you. Thank you.
Yeah, Dr. Grewal. So what's a good time to take it? Like, morning, afternoon, before meal, after meal, as vitamin D, K, they are more fat soluble and
It's another great question. When it comes to, and let's talk a little bit of inflammation. Those of you that treat patients with rheumatoid arthritis know that they go to bed feeling okay and they wake up with their joints painful and stiff. And so probably, unless your patient wants to get up at 2 a.m. and take it, probably the morning is probably the best time. But then again, if a patient takes their medications in the night, I mean, this is not, it's more of, I don't think there's much diurnal variation in this particular, with this particular entity. But if there is, a patient will figure it out. They'll find out that if they take it in the morning, it works better than if they take it at night. And again, or it's just a matter of, it's not a big deal, but they can figure it out. And I think it would be efficacious in both situations. Another great question.
anything, any studies that has been combined with combining hyaluronic acid, maybe giving injection along with this, has this efficacy
Yeah,
increased
it's
or like
another-
the cartilages?
It's another great question. What about giving this supplement and giving hyaluronic acid, or giving this supplement and giving a long-acting steroid injection? I don't know if you have that in India, but I'm sure you do. Those studies have not been done. However, we could probably get that data because most of the time patients will continue their supplements and their vitamins while they get these other treatments. So we could look in some databases and see. In the United States, we have all these big databases now because we have this great electronic medical record, which drives me crazy. But at any rate, we could look at that. That's a great question.
Thank you.
who are on long-term corticosteroids, maybe like ulcerative colitis or lupus or etc. So adding Centrum to them, can it help, or corticosteroids will not help to build the collagen?
Well, that's interesting. Glucocorticoids or the steroids are incredibly anti-inflammatory and immune modulating.
Because in India, lots of patients who are on oral corticosteroids for various diseases.
Yeah, well, we believe it or not, we still have to use them in the United States too, because they're the most cost-effective medication we have. But, and I will continue to work on till the rest of my career, how to keep the bones and other joints, other organs safe for steroids. But that's sort of my other interest. But the supplement UC2 would be fine with glucocorticoids. Would it add more? I don't know. The only reason is because glucocorticoids do some of the similar things as the UC2. They increase Tregs and they increase the Th2 cells. But it would be, again, an important piece of data to know if you could give like 5 of prednisone and the UC2 and see if you got better results. Be interesting. But I don't know of any data. There would be no reason not to give them together for sure.
Okay, sure. Thank you. Can that be used for long-term, Dr. Green?
Steroids can be used for long-term. We try to make the doses as low as possible, but there's many of my patients, I will admit, that I will never get off prednisone, but they can take lower doses of it. So that would be potentially also a nice combination. And it would also be a nice study to see if you could give UC2 and taper off the low-dose steroid or get to a lower dose. So great ideas. I can tell I'm talking to clinicians here.
We do have few questions from the other locations, but maybe we'll check with, yeah. Can you pass on the mic, please? Yes, sir. Whatever.
So myself, Dr. Amit Thackeray. In India, what I've observed is many patients present very late with severe OA, and many of them are not willing to undergo surgery. So can you please comment of effectiveness of this UC2 in such patients?
Okay, so if I understand the question, it's patients that have moderately severe OA
Yeah.
and they aren't able to get surgery. That's a challenge. I'll go down saying though that you can give this, but I don't think that group of patients will benefit. Unfortunately, that's a tough group, but you know, they need assistive devices, try to get them some therapy, you know, to try to improve the muscle strength and get them as active as they can be. That's a tough group. That's a group where they have such chronic pain that their life is taken over by it. And in the United States, I worked for a number of years on a compound called anti-NGF, nerve growth factor inhibitor. Actually had a New England Journal of Medicine paper. And it was very sad, in a way, very sad that the FDA did not approve that medication. It had its issues, but for these patients with severe OA and generalized OA that really are in pain all the time, it was the only way to give them a pain holiday. So my answer, long answer to your question is, we don't have anything good for them, but I would try to find ways to give them pain holidays, even if it's opioids for a week or two, just to give them some sleep and to re-energize, because we all know we treat patients in chronic pain, it really takes their life away. So thank you for that question.
Thank you.
So my question is that we have seen that especially in the Indian market, there are a lot of collagens. There is something called as collagen peptide, which is in the form of powder, which we used to give many years back. It's still available. Then there is, this is the undenatured collagen, I say. And there are some companies which are saying that we have something called as native collagen. So can you just differentiate and help us know basically, is this native is better, undenatured is better, or the collagen peptide, which is in a form of a packet or a liquid, which is better?
Yeah, I can tell you, I'm going to start to answer your question and I'm going to toss it over to my colleague here. He's going to finish the volley. I can only speak to the fact that this UC2 is the one compound in this category where some actual science has been done. Glucosamine, we're pretty sure does not get absorbed. So we don't know unless the microbiome is dramatically changed. That still remains a question. You want to take on some of the other ones?
Sure. So, sir, so UC2 is a unique molecule. So it's not acting as a, as a supplement. It has its mechanism of action, which is through the T regulator cell. To stimulate that action, the native structure of the collagen has to be maintained. That's where the science lies. That's where the innovation lies. And that's what is UC2, patented process by Lonza. So if you look at other collagens, which are not UC2, so the extraction process either uses heat or chemicals to take out collagen, because collagen is available as an animal source. So while taking that collagen out from the animal source, the structures change because you are either heating it or using chemicals. So once that structure changes, that antigenicity is lost. So that mechanism of action will not work. And hence that, the study that I showed you, highlighting that, if you UC2, you only need, 1.5 or the other, collagen, you'll need higher dose, because that antigenicity, the complete mechanism of action, the T regulator generation, etc., will be lost. So, it's more like, just adding amino acid, because, the cartilage has those amino acids. It's kind of that therapy for other collagens.
I understand that, but is there, what you have is the native undenatured collagen?
Yes, undenatured.
So all undenatured collagens are native?
So native collagen means that, structurally it is similar to the native collagen.
Which is there
type
in the
2.
body.
Yeah, in the body. Yeah. But the extraction process is what defines how native collagen is kind of, mimicking the original and if the antigenicity is lost or not. So we just showed you one study wherein, there are other competitor also, which claims to be native, but if you see them under microscope, and Dr. Lane also showed, and I also showed, the structures are lost. So maybe they still have some, native elements to it, but they are not actually native.
So one more question. Is there any research? See, normally when patients come to the orthopedic surgeon, they are normally in a little bit of acute pain, acute on chronic pain. So in acute pain, we will give NSAIDs, we'll give those local applications. So, and we'll start, say, Centrum joint and mobility together. So what should we tell the patient, and what is like, is there any study on this? Okay, after these many days, the requirement of NSAIDs drop down, NSAIDs, paracetamol drops down, and the patient can be maintained only on Centrum joint and mobility.
Okay, there's there's the clinician in the audience. Another one, great question. Okay, sure. So patients are going to come and see you frequently because their chronic low-grade knee pain is worse, right? You can give them a steroid, you can give them a topical NSAID, but you can also start UC2. Now, the challenge is, okay, whatever you give them acutely hopefully will help, but then will they be able to say, stop the topical NSAID and continue on UC2? So what I have done in my clinic in Sacramento is I do treat their acute pain as best as I can because, they don't deserve to be in pain. I start the UC2 and then hopefully after a few weeks, if they're on topical NSAID, they stop it and they go for a while. And most of the time, I think this is an important piece for those of us who treat knee pain, knows it gets bad and then it does get better on its own, even if you don't treat it. So I try to say to stop the topical NSAID as soon as I can and keep the UC2 going. And that tends to work. Most of my patients have a flare. They take topical NSAID or I give them an intraarticular steroid. Usually by about 3 to 4 weeks, they're off that and they're on the UC2. Now, I can't answer if the combination is faster. I wouldn't think so because I really wanted you to appreciate that this takes time for the immune system to change, a few months. So I don't think the combination acutely will make a difference, but this hopefully will take over time. Okay. Okay.
Yeah, Dr.
Have you tried in the small joint osteoarthritis of fingers and toes?
Yes.
With
I use it for hand away and I use the same dose once a day. And, I think it helps. Again, hand away is a funny one, right? It kind of flares and then goes away, but I have a lot of patients, a few dozen patients with hand away that take it chronically. I can't say whether it's better than a low dose NSAID or capsaicin, but it does help a group of patients.
Do you think it is cost effective if you want to, because a lot of patients, they get frustrating experience with small joint osteoarthritis of fingers and toes. Now, do you think it will be cost effective compared to NSAIDs? Because NSAIDs you can't give for a long time with a kidney problem and all.
I think small joint arthritis remains a large challenge. Okay. But look, UC2 is safe and over time can help them. I use some topical NSAID on those patients because it is true that long-term oral NSAIDs are not good. But as a rheumatologist who didn't have all these wonderful biologics in my early career, we kept patients on NSAIDs for a very long time. I think I will tell you in the United States, one of my biggest challenges is not the NSAID per se, but we have these oral anticoagulants that all of my patients take that have AFib and arrhythmias. There seems to be an epidemic of that in the United States, and they can't take NSAIDs. So they have to take, we only have Celebrex, which is the COX-1 inhibitor. So those patients, I try to get them on the UC2 because, worrying about, because you can't give NSAIDs, they bleed just thinking about things. So that's become a real difference. So I'm assuming it's the same in India.
Thank you.
We have a lot of NSAIDs every now. In fact, some new NSAID has come, palmococtu also.
Well, we have NSAIDs, but the
Yeah.
issue is that the patients that are on these blood thinners, these oral blood thinners, they can't take them and they have arthritis. So we're stuck with Celebrex. That's it. So that's why UC2 and these nutraceuticals are really kind of important to understand how best we can use them.
Dr. Lane, if I've understood right, and you showed in your presentation that it's between 60 to 90 days that UC2 actually kicks in and the WOMAC and KU scores start improving.
That's right.
So we would need to counsel our patients
That's right.
that whatever you start, this may be a co-prescription for the first 2 to 3 months.
Yes,
Thereafter, it may be the only prescription.
that's correct.
So I think we need to counsel our patients and handhold them through this entire journey,
That's right.
rather than promise them pain, stiffness, and functionality within a month or two. It may take longer.
I totally agree with you. And
So I
that's,
think that's very important.
it's a paradigm shift. We're going to treat something acutely if you need to, and let the UC2 see how it works over a number of months. That's right. It's a journey. For sure.
Actually, I received that question from one of the locations that on duration. So Dr. Lane, maybe to you and sir, you can add. So for how long is when you see the results with UC2 use, and what is the recommendation in terms of the therapy duration?
Yeah, well, I think that thank you for that question. It's important because the patient wants to know it. I say you have to go the distance for 2 to 3 months and then, decide if it's helping. You're not going to see a lot before that and generally. So that's where you may need to supplement the patient with an NSAID or a steroid injection, whatever you're going to do. But at least 3 months to see if it's going to help, and then keep taking it up to 6 months. And that's where it looks like the studies have shown the maximal effect. So we can only go with where the data is. You all can generate more data and tell us.
So, madam,
Is there a
patients who are not responding, maybe after 6 months also, should we discontinue?
Yeah, I think that from best I can tell from reviewing the studies and the compound, I think 6 months is a good enough time. I think that's long enough for the immune system to adjust and see if there's going to be any improvement from that side. Yeah, I do.
And one more question, madam, you have been using this in RA, rheumatoid arthritis?
Well, that's
psoriatic arthritis?
it's a great question. This wonderful study was done. It really was quite effective. But there was something called the biologics that seemed to take over. And, we haven't gone back to oral tolerance. It's interesting. That was a landmark study, but the answer is no, not in the mainstream. We're not doing it at this time. It's a really good question. If we could give the biologics and get the patient orally tolerized, maybe we could get even better outcomes.
Correct.
I would like you to do that study in India. I will watch for the results.
Okay, thank you.
One question is that now we know that minimum period is how much? What is the maximum period? Is there any study on that?
Maximal duration of
Yes,
use.
maybe 2 years, 3 years,
I
5 years.
think if, osteoarthritis, it's with you for a while. I think if the patients are getting a reasonable response, if they have an improvement in their flare over time and they're getting less flares, they can take it indefinitely.
Okay.
Yeah, it's another great question.
So there is no long-term side effects which have been reported?
No, because at least not that I'm aware of, because mechanistically, the only thing I would say is it's possible that over time it could wear off its effect. I don't know. It takes us out to 6 months for some patients to see a really good response. They maintain it, or I guess the real question is if you'd have to boost them again. Okay, so maybe they would need a UC2 holiday and then give it to them again to see if you could recreate that response. That's theoretical, but if they're doing well on it, especially if they're taking Centrum, they get some other good vitamins that are good for general health, so they can continue it.
Okay, thank you.
Any other questions from any other center?
Yes, sir. I'll just scan. Meanwhile, if there are any other questions from this group, we can just raise your hand and ask.
May I set the cat among the pigeons? You showed a slide where you compared 5 associations in the United States of America, talking about 5 to 6 different modalities of treatment. And there is the ARA, and there is the AAOS. I see for hyaluronic acid and chondroitin sulfate, there's a big red with the ARA. Why is there a light green with a double AOS?
Well, no, it's a very good question. And I probably don't have the best answer for it, but I will say something. When hyaluronic acid and the different derivatives were approved, and this ages me, ages you too, it's that we didn't have COX-2 inhibitors. We just had non-steroidal drugs, and in people with advanced arthritis, they had side effects and they couldn't take it if they had kidney and renal insufficiency. So we had this group, and you couldn't give intra-articular steroids all the time. So we had this group that needed help. So in came the hyaluronic acid derivatives. They helped a little, but they sure didn't hurt. But if you think about it, the idea is right. A normal joint, the chondrocytes and the thin synovium make hyaluronic acid. It's like the oil in the joint. And when the chondrocytes become diseased and the synovium changes, we don't have enough hyaluronic acid, and the joint doesn't have a lot of oil. So the idea of putting it in there is great. There is this is my rheumatologist talking. All the studies show one important thing. It works better in older patients. And I know because when I ski in California, all my 80-plus-year-old ski buddies tell me it really works. Give it to a 55-year-old, it doesn't work. So it is not a bright green light, but there is a group that really uses it. The other thing about hyaluronic acid, and this is a little bit just the bureaucracy of medicine in the United States, is some insurance companies do not cover it, so the patient has to go pick it up at the pharmacy, and we call it brown bag it, bring it to the doctor's office. That also creates a step that is not usual in the United States. But it does work in older patients. It does give them the oil/grease they need to help them. And so that's a long answer to your question, but I think that's the answer.
Yeah, we have to agree to disagree because, as we all know, we still don't have the final answer. So it's good. Any other questions, sir?
Yeah, sir, I think we have covered all.
Great.
Through our discussion, I think we have covered all that have been asked.
Lovely.
So, yeah, maybe if we have any other question from the group, we can.
I think they're ready for dinner.
If not, I'll share the slide, sir, and he's trying to put it. Okay. Yeah. Okay, I think then we are done for the day. So maybe I'll invite my colleagues to say a token of thanks to Dr. Lane and Sir for this one. And of course, thank you all to the wonderful audience. There were so many questions beyond what actually we were expecting. So thank you so much. Just a token of thanks from our end. If you could, Vivek.
Oh, that's right.
Before we invite you for the dinners.
No, I took to the hotel. You take them to the office and to home. Oh, well, we'll give them to someone else. We'll give them to someone local. Well, thank you all, everybody. This was a lot of fun. You're
People
a great
are hungry.
audience. Thank you.
Great. To ma'am first. Thank you, Dr. Lane. It was wonderful. Sir, आप भी थोड़ा हाँ. To sir, thank you, sir. It was wonderful to have your views and your expertise. It always brings value to us. Thank you so much. We can have the photo session later as well. Yeah, so the dinner is now served. So thank you so much. You can join us for the dinner, please. Thank you.
Recording stopped.